And now, I will introduce the last speaker, Dr. Simon Howell, like I commented before, from Leeds University, an active member of the Vascular Subcon. He will talk about the summary of standard perioperative monitoring during vascular surgery. And again, just a reminder, please be sure to type your question in the question box asked to the faculty. Thank you, and good evening, Simon. Afternoon, sorry.
Appreciate, thank you very much indeed. It falls to me to try and bring together what we have heard in the past couple of hours. Perioperative monitoring during vascular surgery, huge topic. This audience really doesn't need me to tell them about the basics of anaesthetic monitoring. This has been covered in numerous guidelines, and perhaps unsurprisingly, most of those guidelines say pretty much the same thing about what core anaesthetic monitoring should look like. And this is pretty much what I imagine we would all do for all of our major vascular surgery patients: pulse oximetry, blood pressure, ECG, gas monitoring, and so on and so forth. I think probably what's important in this is a number of the guidelines make the point that perhaps the most important monitor in the room is the anaesthetist, that all the clever technology in the world is of limited value if there isn't an engaged, informed and capable clinician in the room. And our monitors are important. We are probably more important, but I would like to think a bit about what we are trying to get from our monitors. So why do we monitor our patients? I think for the advanced technologies that we have been talking about or are talking about in this webinar, the primary reason for monitoring is to guide treatment. It's about finessing what we do. It's about the choice of agent, the guiding of blood pressure, and so on and so forth. But there's something inherent in monitors that we are seeking to prevent adverse events. We either want to be alerted to an upcoming adverse event that may occur in the future, or if we may want to be, or we certainly want to be told about things that require immediate action. So a dramatic change, for example, in motor potentials that indicated a possible significant spinal cord ischemia would probably prompt, or should prompt, immediate action. The problem that we have with all our monitors, whether they are advanced monitors or the core monitors that we use on all our patients, are the burden of false positives, the alarms that we really don't want. And we're all familiar with these in our day-to-day work. The false alarms, for example, caused by diathermy disrupting the ECG. Nuisance alarms, for example, the loss of an arterial trace simply because the BP cup has gone up or because we're taking an arterial blood gas sample. Or alarms that don't really add anything to care, the apnea alarm going off during intubation. Now, to some extent, these are part of the background noise that pervade our work in theatre. Nevertheless, I put it to you, they are important in a bad way. They can cause distraction at critical periods when we're often dealing with a lot that's going on and produce cognitive overload. And in the case of the alarms going off before the patient has gone to sleep, or alarms going off when a patient is having a vascular procedure under regional anaesthesia, for example, awake carotid endarterectomy, a loud and insistent alarm has the potential to cause real patient distress. And as I said, we endure a lot of alarm noise to the point it's fatiguing and tiring. So in one study with 25 cardiac procedures, the alarm rate averaged out at about 1 alarm per minute. And we really need to ask if that's appropriate and why it is happening. And I think this applies whether we're talking about the ECG alarming, or whether we're talking about advanced monitoring modalities. And I think a lot of it is around a better the safe than sorry approach, particularly to setting alarm limits. So most of our anaesthetic monitors come with preset narrow alarm limits, which give a high sensitivity for detecting deviations from a preset norm, but a high false positive rate and a low specificity. And the consequence of that is that the onslaught of unnecessary alarms may reach the extent that practitioners may choose to turn the alarms on the monitors off. Possibly not a good thing, but question is, what can we do about this and use of these monitors?